think this is about a good time to get started. Yeah, and then for whomever is gonna be rocking it out, then we're gonna go. And so I would like to kick the meeting off, and I would like to welcome everyone who has come to hear Dr. David Spiegel. Thank you very much, Dr. Spiegel, for agreeing to speak to everyone.
Pleasure.
This very hot topic of why is it so difficult to get a proper diagnosis. Before I get started and introduce Dr. Spiegel, I would like to let everyone know that the next meeting that we're going to have, our community Zoom, is on May 13th at 7 p.m. And we're actually partnering with the SPCA, and they're going to have a representative talk about the benefits of individuals living with mental illness and having that animal companion, and what that looks like and what the enormous benefits can be. So put that on your calendar for May 13th. And with that, I'd like to introduce Dr. David Spiegel. He joined EVMS in 2001 after over a decade of being in private practice. He did a psychiatric residency at Dartmouth and at Hershey Penn State. His areas of interest include behavioral treatments for geriatrics and the interface between cognitive therapy and psychopharmacology for anxiety and mood disorders. Dr. Spiegel is currently a clinical supervisor for psychiatric residents and psychology interns, and presents, as he's doing this evening, to various community partners. And he's done and always been such an advocate and a partner for us at NAMI Coastal Virginia that we welcome you, Dr. Spiegel, and thank you for being with us this evening.
My pleasure.
Yeah.
I got to tell you before I start, Courtney, I want everyone to know who's listening, and I hope it goes out national. I got the best job in the world. I have to tell you. I mean, I got the absolute best job in the world, being able to treat mental illness while at the same time being able to teach about it. Okay. I mean, I couldn't be, I know there's burnout in physicians, but I have to tell you, I'm not one of them. Like I said, this is fantastic. So I appreciate everything y'all do for our community. But like I said, this is a great job. So go ahead. I'm ready.
Ready to roll. We're going to start off and kick it off with probably one of the most obvious questions. As you know, we did pull a lot of questions from everyone who did register. And the first one is, can you kick us off? And I know we're going to go deeper into this, but why is it so difficult for an individual to get a correct diagnosis?
Okay. So I'm thinking about this for since last night when I read the questions, and basically it comes down to a lot of psychiatric diagnoses, a lot of symptoms, should I say, cross over into various diagnoses, right? There isn't just like a one symptom that, hey, that is diagnostic of psychiatric illness. So if you look at the irritability potentially of mania, right? Well, I mean, ADHD patients are irritable. Patients who have certain personality disorders can be irritable in the criteria. PTSD patients have irritability in the criteria. So a lot of, and that was just an example. I can go through others like concentration. A lot of illnesses have problem with concentration in the diagnosis, whether it's major depression, generalized anxiety disorder, mania, ADHD. Again, so the problem is no one symptom makes a person's diagnosis. You have to listen intently to the whole picture and which symptoms are happening concurrently at the same time. All right. And then, and only then, can you come up with at least a working diagnosis, if not a differential, to at least entertain various diagnoses. So to me, the two things are, one, there's a lot of symptom overlap between various diagnoses, and two, it's the job of the clinician to listen to the patient. Okay. The patients don't know the diagnosis. It's not their job to come in, hey, Dr. Spiegel, I think I have ADHD because I can't concentrate. Well, like I said, people who have anxiety, generalized anxiety, they can't concentrate either. Okay. So just because someone comes in and says, I think I have this diagnosis, that doesn't mean they have that diagnosis. It's not their job to diagnose. It's mine. It's the clinicians. We have to listen. And we have to fulfill the diagnostic criteria, not just a symptom. And that's, to me, is the biggest problem.
Do you think that to take that a next step further is one of the reasons is some clinicians aren't listening? Because one of the questions we did get was, why do some clinicians, doctors, not listen when either the patient or the loved one, the parents, are giving details about that history of their loved one or themselves, and it is not utilized for them to make an informed decision?
I think they're listening, but they probably have a diagnosis that they're already kind of honed into, right? And so if I think someone has ADHD or mania, then pretty much most of what the patient's going to tell me, I'm going to view in the line of that diagnosis, whether it be mania, ADHD, whatever. And so I think they're already predetermined, they're focused on this. And I'll give you an example of the big one that comes in is the phrase racing thoughts. And if you look at the DSM, racing thoughts is selectively goes with mania. The problem is what people think is racing thoughts is not racing thoughts. See, racing thoughts should be viewed as crowded thoughts, that thoughts are occurring simultaneously to the point that the person is speaking so rapidly because the thoughts are coming in and out. If someone can list their thoughts to you, I worry about this, I think about this, I think about this. That's kind of the anxiety associated with worrying, not the racing thoughts associated with mania. But again, you have to be able to hear the entire package. My next question would be, well, tell me your mood that's associated with that. Are you elated? Are you irritable? Are you anxious? Are you sad? Because you can't diagnose a mood disorder without a mood. Okay. And so bottom line is you got to be able to not have anything predetermined. A lot of times people wonder if I look at another doc's history or I look at the history, and my general answer is I'm going to do that afterwards because I want to go in there and evaluate the patient free of bias. I don't want to know what anyone else thought. It's not that what they think is not important, okay? I would much rather read what the patient thinks about themselves, and then I have questions beyond that, than what another doctor has. Because every evaluation I do, whether I'm in the hospital, I'm in the office, and it shouldn't just be me, it should be all clinicians, they should start from ground zero. They should start from the very beginning and come up with the diagnosis themselves.
Okay, and then we do have some clinicians that are definitely on the line, and one of their questions was, as a clinician, what do you do when you are seeing a patient and you're trying to make that diagnosis and it is completely contrary to the diagnosis that they received from another clinician?
If I can substantiate it with the diagnostic criteria, what I'll try to do is say, well, I can somewhat understand where this other clinician might have, and being honest, sometimes I can't understand it, a little secret between all of us, all right? But certainly in respect to the other clinician and to the patient and for their time, I can kind of understand where they might have been going, but let me tell you why I think you have this, okay? Or why you may not have that. One thing I can't underplay is the role of substances. If there are two things that change a diagnosis, and I know this question came up about trauma, so we will answer it. Childhood trauma, adult trauma, and substances. On the thought that, let's say, medical conditions can do this, but for the most part, not always, but for the most part, people aren't coming in psychiatrist's office with a huge medical diagnosis that's been missed. I've had plenty of patients who've had lupus that has caused mania, autoimmune encephalitis causing psychosis, but for the most part, that's not walking into the office on a daily basis. So Substances, sexual, physical abuse change the game. Okay. They change the game psychiatrically, they change the game medically. And if you don't hear that, okay, that's a problem, because the hallucinations that people I've seen diagnose someone with trauma is not the same quote unquote hallucinations of the patient with schizophrenia or schizoaffective or mania with psychosis, it is a completely different type of hallucination. And when in fact the patient is really not psychotic, if anything, it's called secondary psychotic symptoms of PTSD. But at the end of the day, if you don't take the time, you, not the patient, if the physician or clinician doesn't take the time to hear that, to hear the trauma, okay, does that mean there can't be a schizophrenia patient of PTSD? Of course they can. But there are much more misdiagnoses the other way, that people have PTSD because they have hallucinations of the trauma, which is reliving, or because they have paranoia, because they've been abused or assaulted. They put them as psychotic and delusional, or in the realm of a psychotic disorder, when in fact it's PTSD. So what I'm saying is that that's a huge thing to miss. Substances are a huge thing to miss. Too many of our substances resemble psychiatric illness. And if you look at every psychiatric, I don't want to say everyone, most psychiatric diagnoses, you can't really diagnose them unless you know for a fact that substances are not playing a role in the symptoms. Okay. I have seen more patients that have had cocaine intoxication or stimulant intoxication diagnosed with schizophrenia, okay, and mania, okay, bipolar, when you clearly can't do that. You got to take that into account. All right. And so if that's my real caution. And I don't think the patient should be the least bit embarrassed or reserved to tell a physician their whole history. Without these key pieces of history I talked about, and I can understand why they be reserved, because we're not talking about things that are run of the mill. I mean, substances are not run of the mill. Trauma is not run of the mill. Okay, once you've been violated, it is beyond what a human brain can comprehend. So that's my take. You got to listen to that. You got to listen, because there are clues that can put you in the right direction. But if you just hear, I have auditory hallucinations of someone yelling that I'm a horrible person, well, maybe it's the person that is there reliving the trauma, okay, of what happened to them, and that's being called they're horrible from the trauma, not this other idiopathic hallucination, this other hallucination of schizophrenia. But that's why you have to listen. You can't shut it off at the end of one symptom.
And I mean, you sort of are answering this a little bit, because I would imagine this is how you do talk to your clients in the informing stage once you have listened. But how about for not only our clinicians that are on the line, but as well for patients, like how do you talk to a client about their diagnosis? Because there are still so many clouds around some of the diagnoses. This is a little softer than this diagnosis. So, and they can be such a trigger. So how do you go about your approach in making this work?
Well, again, it's going to be what diagnosis. I have plenty. I have a small minority, but there are patients who will not accept what their diagnosis is. Usually substances are involved with that, but I have some that won't accept it, and I can only do my best. That said, I really, it's just like a medical diagnosis, right? If someone's going to tell you you have gallstones, okay, and you got to get surgery, you're going to tell the patient what it is, right? You're not going to just give them surgery without saying, oh, by the way, I just want to take your gallbladder out. You're going to tell them why they think they have what they do. So it is no different for me when I sit down with the patients and tell them their psychiatric diagnosis. It's no different. And if they have questions as to, hey, I'll always say, what do you think about this? What's your impression of this? What are your questions about this? One of the questions I saw yesterday was about the bipolar borderline personality disorder, schism. You know, and this is a very tough one. This is a very tough one.
Yeah, let me just clarify this one. We did receive a question, and it was that difference, that fine line between borderline and bipolar. And so, yeah, go for it, just so everyone knows the
Okay.
back end.
So, and I'm going to add that, you know, substances are not uncommon in both groups, okay, of this. So I often put substance in there. So the biggest difference would be, one, is the symptoms sustained just about the majority of every day during the episode. So if you're manic, you know, or hypomanic, you know, 4 days, 7 days, 2 weeks, 1 month, however long the manic episode lasts. But after it's over, there's some emotional instability, but for the most part, they're coming back to what I'd like to think of as a normal, non-depressed, non-manic state. The borderline person, or even anyone in that quote unquote cluster B diagnosis of impulsivity, okay, it's very short-lived. Their anger is intense, but very short-lived. All right. You may even say their periods of quote unquote normal, non-depressed, non-irritable functioning or symptoms are short-lived. All right. They get very easily angered. Okay. They are environmentally triggered. The manic patient, the bipolar patient, is generally not environmentally precipitated. And if they are, it's certainly not to the degree of the personality disordered patient. All right. And so then the question becomes, well, doc, I want to medicate, because that's what you're here for, right? You're here to potentially medicate a symptom. You know, borderline personality disorder, narcissistic, histrionic, and to a much less degree antisocial, they don't really respond great to medications. I mean, that's the huge problem. You're trying to medicate a temperament. You're trying to medicate someone's personality. That's not going to be medicationable, at least readily medicationable. Whereas bipolar mania is much more amenable, much more responsive to medication. At the same token, therapy is much better in the borderline patient, in the traumatized patient, than obviously mania is going to be, right? I mean, mania is a highly biological illness that's, you know, going to respond to meds. Go ahead.
Okay.
All right.
Oh, no. Go ahead. Yeah, no.
No, that was, and you know, then, you know, the question becomes afterwards, and this may be the worst reason of all to be diagnosed with bipolar as opposed to borderline or any of those other cluster B, which is, if I diagnose you, Courtney, with borderline personality disorder, you don't have it, but I'm just saying, if I did, and I tried to quote unquote bill that, I wouldn't get reimbursed. Okay. I can't get billed for that. So on your billing sheet, and you get this sheet because it's now printed out, I gotta write something if I'm going to bill something, if I'm going to get paid for this hour. So the quote unquote, the instability of mood of borderline gets thrown in to the elated / depressed moods of bipolar. It's a horrible thing. It's a horrible reason to do it. Okay. But that's a reality. And so patient sees that diagnosis, well, Dr. Spiegel diagnosed me with bipolar 2. Generally speaking, what Dr. Spiegel will do is usually put down a persistent depressive disorder and not bipolar, right? I don't put that's because that's a different ball game. I mean, bipolar is a very serious illness. Okay, not that persistent depressive disorder isn't, but not to the degree of impairment that potentially mania can do. All right, so I will do that, but at the same token, I will tell the patient, temperament, we all have a temperament. Everyone on this screen, Dr. Spiegel especially, okay, has a temperament, all right? And so to tell you that temperament is not going to affect psychiatric diagnosis would be like saying to you, sugar will not affect diabetes, right? That's ridiculous. All right, of course it will. So the bottom line is that if you have someone who has a chronic depression and you throw in the ingredient of temperament, this is where kind of the instability of mood comes from. So that's how I explain it, that, hey, we all have a temperament. Part of our times, our temperament's great and people want to be around us. And part of the time, Mrs. Spiegel doesn't want to be around me. All right. And that's just when she has much better taste and insight. So anyway,
Well,
that's my spiel.
And that probably takes us like even one step further, right? So what you put down in order for, to be paid for your time to fall within the construct of what we have right now to work within, as a patient or as a loved one, when you get that back, do you feel that it is fair for an individual who gets that back to dig further with their clinician as to why, and to keep advocating either for themselves or their loved one in order to drill down to get the very best possible information?
Yep. 100%. 100% the patient should leave the room knowing what their diagnosis or diagnoses are. They should leave the room knowing.
And if they don't, because this is something at NAMI that we get a lot of calls about, particularly from family members and loved ones, of really negative experiences that they've had with clinicians, not feeling that they're being heard at all, but not getting what they need to give their loved one the very best possible chance within their recovery. So would you think that would be a fair time for someone to then say, this isn't a match and I need to move on, I need to go to a clinician that I can align with?
Yeah, the patient shouldn't leave. I don't leave any physician's office, all right, without knowing what my diagnosis is. Okay. I don't care if they tell me, we don't really have an idea. Yeah. I have left before I got diagnosed with celiac sprue, I was diagnosed with irritable bowel syndrome. Right. And for all intents and purposes, I was like, well, it doesn't quite sound like me because I kind of know what irritable bowel syndrome is. And I don't know if that's, so my point is that I don't leave until I know and I'm satisfied with the diagnosis. Same thing should be for the psychiatric patient. They should expect nothing less. I have an hour with you for the first meeting. I have 30 minutes for the second. I have an hour for the first. No one should leave that room unsatisfied with either what the diagnosis or diagnosis should be or could be and what they are. It's your history. It's your diagnosis. You should know. You should ask the physician 100%. The worst case scenario, say, well, maybe I need a second evaluation to be convinced, but all right. So that's my recommendation. Don't leave until you are satisfied that you have a diagnosis. You're putting a pill in your mouth, by gosh, right? I mean, you're putting a pill in your mouth to treat something. I'd like to know what I'm putting my pill in my mouth for.
Right.
So yes, ask. I'm sorry, physicians, if everyone doesn't listen. That's why you came into this field. You came in psychiatry to listen, right?
True, but one of the things we hear quite a bit is that, we're on our 5th psychiatrist, right? We have 5 different diagnoses. And in this case, it's a lot of people who have loved ones who are living with mental illness. We still don't have an idea or any clear path of what to do. We're told to do this, but then when we go to do this, they say, oh no, you don't qualify, you don't meet criteria for this. So then we go back to the original psychiatrist that gave these recommendations, said, well, what do we do? Well, that was my best recommendation, right? So it's like this long road that a lot of individuals are on with their loved one and still don't have answers, still don't have any kind of satisfaction. So you might be getting a lot of calls because they're not even giving that first hour of truly digging in, and then maybe saying, you know what, because you've had 18 hospitalizations in the past 10 years and you have this massive history, we've just gotten to have this hour. I want to now review some of your history and then bring that into the next time we see one another. And would it be fair for everyone to say that then that second time that it's not going to be cut off at a 20-minute, 30-minute, that if you need another hour, you're going to be able to make that happen, not only getting paid, but also giving best care?
You can speak to the clinician. What you want to do is speak to clinician at the end of the first interview. That if you need another hour, clinician needs an hour, then absolutely say to the clinician. I have patients say this to me all the time. You know, Doc Spiegel, I really like an hour for my next appointment. Okay, I can do that. That's fine. All right. But what you don't want to do is leave and then come back and find out, my guys only scheduled me for 15 minutes. How am I going to get what I need? All right. It's advocate for yourself. Make sure the physician knows what you want when you are leaving. My follow-ups are 30 minutes. Okay. But if someone wants an hour, not a problem. It's not a problem at all. So if I need the hour to sit with them and review it, not a problem at all. Okay. The other thing I recommend, Courtney, in that scenario, if you're getting 5 different diagnoses and we're not really sure where this is going, what I would honestly recommend is to get an MMPI at a psychologist's office and find out. You could, you get 10 people seeing an accident, right? You get 10 different accounts, right? You get 10 different psychiatrists, you may get 10 different accounts, all right? What you can't get on an MMPI, which is the Minnesota Multiphasic Personality Inventory, is anything but one interpretation, okay? You can't trick the computer. You can't trick the test. This can't be open for interpretation. Hey, I'm getting an appointment now. All right, can't be open for interpretation. That's what I would recommend. And in fact, if I'm not sure what's going on, I will absolutely refer to MMPI, and I'll get the results back in 2 to 3 weeks. And at the end of the day, I'm going to know what's going on, right? Between my interview, I use a lot of MMPIs. I am not a proud person. If some other specialty can help me, by gosh, I'm going to use it because the person's trying to convey something, right? I come in with my own set of biases or training. The patient explains it the best way they can. Maybe we're not fully connected. I like to think I do. Maybe we're not. But that MMPI is going to tell me what I need to know. All right. They're going to tell me what. And sometimes, not a lot, but sometimes I am truly surprised that, wow, I really missed the boat there. All right. And that's okay. I'm human. I can miss a boat, but the computer won't miss a boat. If a person, if a person tries to make themselves look too good and too healthy, the MMPI will pick it up. If the person tries to make themselves look too bad, the MMPI will pick it up. Okay. So it's really a good test to get solid information. Perhaps the only weakness it has is that it doesn't do a great job with an acutely manic patient. I would have said, I'm not going to miss that. Okay. Someone's acutely manic, I'm not going to miss it. I don't need their help for that.
I know we'll get this question, so we're just going to put it out here. You said you refer out patients out to get an MMPI. Where does someone on this call who's listening to you who says, "Oh, I've never even heard of this. Where do I access this for my loved one?" Where do they go? What do they do?
So EVMS, we have a psychologist who does an MMPI. Scott Sauter, Sautter, is a clinical neuropsychologist. There's a huge practice in Virginia Beach that they give out. Many of the clinicians there give out MMPI. Many of them do. Those are the 2 biggest ones that I know. I know our guy, Dr. Handel, has worked extensively on the MMPI, has published on the MMPI, and Dr. Stouter is great, by the way. Scott is a great psychologist, so he can do it too. And so that's what I would do. Again, there is no misinterpretations here. No misinterpretations. Nothing's going to come out unclear. You're going to know for sure what's going on.
Well, and that actually answers some of the others. I mean, we had a mother write in that her son has already had 4 different diagnoses, and what would be her best way to proceed and to get a clear assessment of her son's illness and what to do.
That's exactly what I would do. If there are 4 people coming up with 4 different diagnoses, I'd want to know why too. I mean, I'd want to know what is being what's so difficult to figure this out. But there are things that are difficult. Like I said, substance is difficult. There was one question I think I read about what's the hardest diagnosis to pick out. And I'll be honest, probably the hardest one to pick out is someone who's truly has bipolar 1 or bipolar 2, and they're coming in complaining of depression. And the reason why I say that is because in bipolar, you're not generally seeing both poles at the same time, right? If you're coming in depressed, I'm not seeing you manic or hypomanic. So at the end of the day, I've got to go on your history of what is hypomanic and manic. And I got to tell you, like I said, I'm very, very, very finicky on what meets mania and hypomania. They're not that common, right? They're not that common. It's only 1% of the population has bipolar 1. Though it's less than that for bipolar 2. I think they quote 3.5% for bipolar all of bipolar in general. Okay, so it's not that common illness. And for me to see so many people that have that coming in that diagnosis, something's not right. Something is not right. Statistically, numerically, that doesn't work. Now, we're obviously going to see more of them than the general population, but personality disorders are certainly much more common. And I'll be honest with you, the cluster B personality disorder, your antisocial personality disorder, your borderline, your narcissistic patient, they use a lot more resources than bipolar 1 does. They use a lot more resources, okay? I wish my bipolar 1 patients followed up with doctors like my cluster B patients do. I wish they did, because they'd get significantly better care if they did. All right. A lot of them don't have the support, which, by the way, I mean, support means everything. Family support, spouses, whatever, means everything. Without it, the prognosis and the overall outcome is night and day. It's night and day. And trust me, I know this because I work my office where most of my patients have pretty good support, and I work in the hospital where most of my patients have horrific support. Okay. And so the outcome is so different between 2 people that have similar symptoms, but support is everything. Okay. And the definition of support, I can't even go into how many facets that is. So.
And that is very insightful, because that is, one of the things that we hear probably the very most is my loved one was diagnosed, they have bipolar disorder. I mean, that would be our number one, right?
Right.
And then second behind that is probably the depression, and then slash more serious with the schizophrenia and schizoaffective. To sort of change gears a little bit, research into DNA and mental illness, and maybe even we know there's definitely a genetic component that is present, but maybe talking about some of the genetic testing and some of the research that you are familiar with that's happening now.
So as we know about depression now, it is a polygenic illness, meaning a lot of genes contribute a little bit producing this symptom, which, by the way, it's genes meaning environment, right? Major depression is heritable to the tune of depression is heritable to the tune of about 40%, a little less than that. Okay. So right now, there is no one gene. There is no quote unquote Mendelian genetics where you cross big M with small m and you get, we don't have that. The research is looking at genes that code for various proteins. The biggest one out there right now, which shouldn't be a shock to anyone listening, is the serotonin transporter. The serotonin transporter has a long arm and a short arm, and that can predict illness. It might be able to predict drug response. So, I mean, that's out there, but there are mixed findings on that too. Some very positive, some very less positive. So that's where right now it's headed. We're trying to find genes that can really solidly predict who's going to develop major depression and what the treatment might be. We're not there. We're not there. The only thing we know right now about at least let's say major depression, is that early onset and recurrent illness seems to be more genetic. So recurrent depression, early onset tends to be more biological. All right, but that's about it. That's about
what outside of depression. What about some of the psychotic illnesses?
Again, they're a little bit more. Those are a little bit more genetic. Those are a little bit more genetic as we come along. A lot relies on the dopamine 2 transporter, dopamine 2 receptor. I'm sorry, and that's involved obviously in schizophrenia. So there is strides to be had. It's not going to happen in my lifetime. I don't see that happening in my lifetime. I do see it happening. People who are in their 20s now and 30, I do see that happening for them, not for me or my treatment lifetime. You know, what do we have? So people ask me a lot about GeneSight and about the testing that you swab in terms of cytochromes, in terms of metabolism. That's the one thing out there that we do have pretty readily available. Keeping in mind, and this is where I get a lot of people making mistakes, that it, quote unquote, it'll tell me which medication is going to work for me. No, it does not tell you that. There's nothing out there right now that tells you which medication is going to work for you for psychosis, for mania, for depression, anxiety. All right, so that's not out there. What is out there is you can find out how quick or slow a metabolizer you are. And then that can predict potentially tolerability, maybe dosage. That might be able to pick, if you're a rapid metabolizer, in other words, you get rid of the drug too fast, you might want to raise the dose. If you're a slow metabolizer, you may want to lower the dose. Okay, that's what it'll tell you. It tells you which drugs you're not going to be able to tolerate, and which drug, if you take it the regular doses, you may have untoward side effects. So that's what we got right now. I've had many patients say, I hear there's a test out that can predict which medication works for me. No, that we are not there. We are not there. PET scanning, you know, functional imaging out there. Again, at this point, the fact is there are so many circuits involved, and the people that, you know, do it would say, my gosh, this will help you diagnose. No, because we don't know if the activation or the underactivation is a cause or effect. We have no idea whether it's causing it or that's what you get because of the illness rather than cause. So we're not there yet. We're not there.
Well, that's not very encouraging.
Well, I mean, look, okay, that's not encouraging, but what it does, what makes psychiatry beautiful is what we've talked about is that it probably is the most clinical. So I get, you know, joked around by my colleagues about, you know, psychiatry not being a real science, and you don't wear a stethoscope around your neck and blah, 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 blah. And first of all, stethoscope does not look good as a tie or the necklace you're wearing, Courtney. So I don't want to wear a stethoscope around my neck. All right. But because it's so clinical, because everything I get is based on what the patient tells me and what I'm observing about the patient, right? You know, what the patient with schizophrenia, people, you know, focus so much on the hallucinations and the delusions, but what I'm looking at is the patient at all, as a patient at all odd? Is the patient at all different in how they present their history to me, right? There's a detachment involved, okay? It's kind of like how the autistic kid will relate. You know, there's not the normal give and take of conversation. Okay. I can see whether or not they're disorganized in their behavior, disorganized in their speech, right? I don't have to ask them. I can just observe that. All right. It's the best clinical science in the world where I can't rely on a test. I mean, the MMPI is going to be helpful, yes, but I can't give you an MRI and say, oh, by the way, guess what? You have a bipolar 2. No, I can't do that. I can tell you with an MRI you don't have a tumor. I can tell you don't have a stroke causing it, but I can't tell you what you got. But I can by listening to you and not being put into any corner of what the diagnosis is. What impulsivity? Let me talk about impulsivity for a little bit. All right. I'm being impulsive. All right. So when I have plenty of patients who will tell me, Dr. Spiegel, I have bipolar because I'm real impulsive. I spend a lot of money I don't have. Okay. I go out and do reckless things. I go to bars and drink. And yeah, that's impulsive. That's impulsive. But you know what? There are a lot of people who spend money because they feel sad and they're trying to spend money to make themselves feel better. There are a lot of people just financially irresponsible. Okay. There are a lot of people who have, unfortunately, indiscriminate sexual activity because of whatever reason. Okay. So I think when a patient comes in and leads that with that impulsivity, ADHD, by the way, it's in the criteria for ADHD. I mean, they're impulsive, they're hyperactive, impulsive. That's in the criteria. All right. So again, impulsivity is not in and of itself going to make me think you are bipolar 1 or bipolar 2, or even a mood disorder. Okay. There are so many things that can do that. And that diagnosis, that symptom, again, sways so many clinicians. All right. In terms of diagnosis. And there are a lot of reasons for this. There are a lot of which is why I come back to, you don't get hooked on any one symptom. Don't get hooked on any one symptom. And that will make it. Mania and hypomania, they occur for every minute of every day for 4 days, 7 days. And they're not there 50%. I'm not just spending recklessly 1% of the day. I am reckless majority of the day. All right. Not the majority, just about all day for 4 days consecutively. That's a lot different than me going out one night and drinking and having indiscriminate sex. Unfortunately, a lot of college students and beyond do the same exact thing. And if they're all manic, okay, then we're going to run out of lithium. All right. And so the bottom line is you got to listen again. Don't be bought in by the one symptom. All right. That doesn't mean a hoot. Not at all.
I think that's probably one of the very biggest takeaways from this, because often I don't think that the listening is taking place. And if we were going to take one thing, if they are not listening to the entirety, not telling you what you want to hear, right? Because there's a difference there, but truly going to a diagnostician who's going to parse all of this out. Yeah, so we appreciate that. Oh, quick question, and this was probably a little bit of a side, but you're a general practitioner. How much training do they get in their residency in order to make a proper mental health diagnosis? Because that's being done quite a bit now too, particularly in the mood space.
They don't really get any treatment. They don't get any training. That's not happening with internal medicine. Or if they do, I'll have a family practice person around me for 1 day. I'm not sure if 1 day you can do it. So what I would say is that in places where a person can't get in, they might be able to start. But I do think in terms of the family practice, and God bless the family practice and internal medicines, they got so much to cover in so little time. But I don't know how you can extract a diagnosis that requires you to listen, okay, in 12 minutes and be able to do the rest of the body that they have to do. I don't know how they're going to be able to do that. So it's a start. It's better. I'm assuming it's better than nothing. I don't know if you'd want me to diagnose cholecystitis, gallbladder problem. I don't know if you want me to diagnose an appendicitis. I mean, I did a year medicine. All right. And so, I mean, gosh, I mean, I certainly have a little bit more, but I don't think you want me doing that. All right. I don't blame you. I don't want me doing that either. So it's a start. Like I said, I respect them for what they do and what they are trying to do. It's just hard. Oh, but the other thing which I did mention, the amount of digging I do and what I repeat to the patient, all right, if you should have your psychiatrist, your psychologist, your therapist repeat, okay, what your symptoms are. Because I will repeat what my patient tells me, and it goes like this. Let me see if I understand what you are telling to me. You are telling me that you have this, this, and this, like this, for this amount of time. And if I'm wrong, interrupt me, okay? Because this is important. So if the physician should reiterate what you had, they should repeat what you have, because otherwise, I'm not sure if they're listening. All right. So that's imperative to me. Okay. Now back to the GP. Like I said, depression, maybe major depression, maybe. Like I said, I think it's too hard to diagnose bipolar in 12 minutes. Okay. I think it's too hard. It takes me an hour. I've done this for 35 years. It takes me an hour. Okay. So not that I may be stupid, but I don't believe I can do it in 12 minutes. All right.
And I mean, there are a lot of our members grasping at straws only because in order to get to see a psychiatrist worth their weight, right? That wait can be interminable. And so they're looking for something right now before either they or their loved one goes into a massive crisis. And so there is that fine line, and wondering, that's good advice, that if you can't, does it put the patient at a deficit to have that drug exposure, let's say written by their GP, before they can get a proper assessment by psychiatrist in terms of?
No, I don't think it's going to hurt. I don't think it's going to hurt. I would tell you again that, ADHD and bipolar together, stimulants, giving a stimulant to someone who has bipolar is probably a really bad thing. Okay. On the flip side, if you're giving a mood stabilizer to someone who has ADHD, that's probably not a huge problem. It's not going to help, but it's not going to hurt. Whereas the opposite is very real, right? It makes someone psychotic, you make someone manic. So I say this knowing that there are exceptions to the rule, but for the most part, it shouldn't be a problem for the most part.
Okay. Because we get calls a lot saying my loved one has schizophrenia and they're on an antipsychotic. They were just put on an amphetamine stimulant.
Something's wrong.
Right. But I will tell you, over the past, let's say even 3 years, we've probably had about over a dozen incidences of those kind of calls, which leads us, and we're trying to be educated so we can help the people that we're trying to serve, to give them, it might be time to find someone.
Yeah, they shouldn't be coming. So one of those diagnoses are wrong. Okay. One of those are wrong. I don't know which one, but one of them is wrong. And I've seen people coming into the hospital on 100, 120 of Adderall, and, they're psychotic. And, there's just some things that are just a little bit scary that come to me, that I see. I would probably say to everyone in this room, and I'm not saying there aren't exceptions, I haven't seen a reason where if 40 of Adderall isn't cutting it, then something's wrong. Something is wrong. Okay. I don't know what. It may come down to the wrong diagnosis. Okay. Something is wrong, because the only thing that 40 minutes, you don't lose the anti-ADHD effect of stimulants. Okay. for the most part, once you find the dose, you don't lose it. What you do lose is the euphoria, the energy, okay? Maybe not sleeping, all right? That you do lose, all right? So the question is the clinician treating ADHD or is the clinician getting the patient high? Oh, and by the way, if you go by the question, the symptom, you know, I'm not feeling that good anymore on this. Okay. You know, I want you to feel less ADHD, less depressed, less manic. Feeling good, okay, is a lot different than feeling non-depressed, non-manic, non-psychotic. Feeling good has to come from biopsychosocial. You have to kind of do things to make yourself feel good. I love to tell you it's my job to make you feel good. And I try my best with my patients with my sense of humor, okay? But I can't do that. I'm not there the other 167 and a half hours with them the week, all right? I can make you not depressed, okay? But I can't make you feel good. And if a stimulant is making you feel good, by the way, I look at anyone here who's not manic or schizophrenic and say, by the way, if I told you I give you this imaginary medicine that gives you energy, makes you concentrate, and makes you feel euphoric, really, who the heck wouldn't take it and say, I don't feel good? My God, that sounds great to me. I mean, I love that. So again, it comes down to what am I treating? You can't just always say, well, it was working and now it's not. So again, that's just something else about stimulant stuff. So.
And I know we're sort of coming up against the clock and want to be respectful of your time. And I think you definitely answered a lot of the questions that were posed to the group, without getting into really specifics into the levels of depression or the levels of psychosis on that.
I'll tell you, I'll answer that real quickly. Levels of depression, all that means mild, moderate, severe. Mild is 5 to 6 symptoms, moderate 7 to 8 symptoms of major depression, and all 9 symptoms is severe. That's what it means.
Okay.
So that's all it is. There's no trick.
Box is checked right there for that question.
Box is checked. There's no trick.
Absolutely. And do you typically, just to round it out, when you're talking to a client, do you typically try to focus on the symptoms and then give that diagnosis is like at the end, like wrapping it up? Or do you lead with diagnosis after you've listened to what you are observing and hearing them say about their symptoms?
Diagnosis comes at the end because there's too much other stuff I got to get before then. Symptoms are good to treat. Functioning is better. Okay. Functioning is better. Okay. I don't, if you ask me if I had a patient who had some symptoms of depression, okay, or anxiety, but they were functioning, they were out there in the world doing what we do. Now, granted, in COVID, I don't know what we do, but whatever we do or did, all right, that is a better case than someone who tells me, well, my symptoms are good, but I'm still not doing anything. What have I treated? It's very similar to the chronic pain paradigm, right? You could tell me that I have no more, my pain symptoms are better, but I'm not doing anything. That's not a successful outcome. Okay. Successful outcome is functioning. Okay. And I don't care what you do for your functioning. I don't care if it's work, family, exercise. I don't care what it is. Okay. Mine's talking to you guys from 7 to 8. All right. My point is that that's just as important, if not more important, than symptom relief. I didn't do my job fully if I can't get you functioning. And at least come up with ideas to get you to function better. Okay. So that's all part of the outcome. Last statement, by the way, about diagnosis, and I know I'll go because I know everyone else is busy too. So adjustment disorder versus depression, major depression. Okay. Most psychiatric illnesses, there is something that happens that triggers something. All right. if you have an adjustment disorder, an adjustment disorder is basically you don't meet the criteria for major depression. You may have a depressed mood, but if we get you not thinking about your stressor, whatever that is, and you are still able to engage with others, function, okay? You don't have the remainder of the symptoms, okay? The question comes is, do you need an antidepressant at that point? And the answer, of course, is absolutely not. Absolutely not, you don't. Here's where diagnosis is so important, all right? And it's just another example. The difference between me giving you, if I give you an antidepressant and you had an adjustment disorder, which, by the way, will get better by itself. It's going to get better because it does. You do get nothing, you'll get better. But if I give you an antidepressant and you felt depressed at a time where you had a stressor, but not the rest, what the patient will take out of that is that antidepressant really helped get me better. And it had much less to do with my own determination, my course of time, course of illness. So then it's hard to get the patient off the antidepressant. Are antidepressants really toxic? No, they're not. I mean, within reason. But the point is, adjustment disorders don't require antidepressants, whereas major depression does. And I also see a lot of people that have adjustment disorders that if I even brought up the thought, I don't know if you need this antidepressant anymore. No. Without that, no. You can take away my Diet Coke, not me. You can take my diet, but don't take away my antidepressant. So it all comes down to why we spend time with the right diagnosis. Don't leave it unless you know it. Make sure the clinician reiterates to you what you said to them, because you want to make sure I understood everything you said, because if I didn't, that could change the diagnosis. And at the end, understand what symptoms they are trying to treat with what medication. All right. You don't want to put anything in your mouth, okay, that you don't think has a purpose. All right. And so that's the way to get the right diagnosis. All right. Make sure, and by the way, I can say the trick, make sure they're listening. You ask them, Doc, can you just tell me what you think I said? Because I should be saying that to you anyway. That's, like I said, that's what I should be saying to you. Let me sure if I understand this. All right. I just want to make sure you understood exactly what I said. And if they don't know, then you caught them not listening, and not good. Not
That's
good.
an amazing tip.
Not
And if they're
good.
not listening and you continue, you've asked that and they're not able, then it's time to move on. And we're here, Dr. Spiegel's here. We're all here to help.
And it's time to retire. It's time.
Absolutely.
I just said to you, I got the best job in the world. I shouldn't be off. I shouldn't be at a point where I'm not listening. If I'm not listening to you, and that's what my job is, good God, what am I doing? What am I doing? I shouldn't be. I can roll an ice cream cart. And by the way, I used to do that back in the old days. I used to do that back in the old days when I was trying to make money in college. I wheeled an ice cream cart. You don't know what people can say to you when you charge them for ice cream. It's very sad. I think it was like a dime or a quarter. And I was like, my God, take it easy.
Exceptional. And we're glad you've got a good 10, 15 more years in you. So
I got a good 10, 15 more years. And like I said, I will, whatever I'm going to do when I'm 73, whenever I quit, it's going to be hard to find something that I enjoy as much as I'm doing now. So.
Well, we are lucky to have you, and thank you very much, everyone, for participating, everyone on Facebook live stream. This will be recorded. It'll be up on our website. Thank you to Jessica and Jen for putting this together.
Thank you, guys.
The most extraordinary women. And thank you, Dr. Spiegel.
Thank you, Courtney.
Appreciate you very much.
I appreciate everyone. Thank you all. Have a great night.
You too.
Bye-bye.